Welcome back guys. Now in this video let's discuss about calcium homeostasis and the hormones which are regulating the blood levels of calcium. Now we all know from the beginning of the topic, from the beginning of the chapter endocrinology, everywhere wherever possible I am discussing about the calcium. The three important hormones which are regulating the calcium homeostasis is parathyroid hormone, that is a PTH, as well as a vitamin D. See, vitamin D, it's a vitamin, but it is considered as a hormone. Okay, wherever you have this MCQ, okay, this is a very famous MCQ which will be coming especially in the exams. Vitamin which acts like a hormone is vitamin D. Okay, it acts like a hormone. It mainly involves in the maintenance of the calcium levels in the body. So parathyroid hormone, PTH, vitamin D, that is calcitriol. The other name of the vitamin D is calcitriol. Let me write it down here. Calci, C-A-L-C-I, calci, T-R-I-O-L, calcitriol, which is also called as 1,25-dihydroxycholecalciferol. Okay. Now, apart from these two hormones, there is also one more hormone called as a calcitonin. Okay, calcitonin also involves in the maintenance of the blood calcium levels. First of all, let's talk about the parathyroid hormone. See, when the parathyroid hormone is going to come into your blood, first of all, who produces this parathyroid hormone? See, parathyroid hormone is produced from the parathyroid glands. You are having the 4 parathyroid glands. Now, the parathyroid glands are having cells called as the chief cells. Okay, parathyroid glands are there. They are 4 in number. They are present back to the thyroid gland. Now, these parathyroid glands, they are going to produce a hormone called as a parathyroid hormone. Now, this parathyroid hormone, the main function of this parathyroid hormone is to increase the blood calcium levels. It increases the blood calcium levels. But when do you want to increase the blood calcium levels? Whenever they are falling down, okay, whenever they are going down. So, what I am trying to put into your mind is, see, whenever there is hypocalcemia in your body, okay, your blood calcium levels are going down, you are having hypocalcemia. That hypocalcemia is going to stimulate, okay, that hypocalcemia is going to stimulate the parathyroid glands, are the chief cells of parathyroid glands. So, the chief cells are all the time, they are sensing the blood calcium levels. So, whenever there is a hypocalcemia, okay, that hypocalcemia is going to activate the parathyroid glands. Now, these parathyroid glands are going to produce a hormone called as a parathyroid hormone. Now, tell me, what is the stimulus for the parathyroid hormone? See, the major stimulus is decrease in the serum calcium. Don't confuse. Don't say parathyroid hormone is going to decrease the serum calcium. No, I am talking about the stimulus. The major stimulus for the PTH release is hypocalcemia. So, hypocalcemia is going to stimulate the parathyroid glands, and the parathyroid glands are going to produce a hormone called as a parathyroid hormone. Okay, well and good. Now, what this parathyroid hormone is going to do? See, let's talk on the bone. The parathyroid hormone is going to act on the bone. It is going to act on the osteoclasts. Okay, it's going to act on the osteoclast. It's going to activate the osteoclast. So, bone resorption will happen. Okay, bone resorption will happen. When the bone resorption happens, blood calcium level will be increased. Okay, so usually bone resorption, parathyroid hormone activating the osteoclast, causing the bone resorption, it will happen in more severe hypocalcemic states. Okay, whenever there is severe hypocalcemia, then only high quantities, high levels of parathyroid hormone is going to stimulate the osteoclast so that bone resorption follows, like bone destruction leading to increased blood calcium level. This happens whenever there is severe hypocalcemia. Usually this won't happen. Okay. So, whenever there is severe hypocalcemia, parathyroid hormones, higher levels of parathyroid hormones, okay, not just the normal levels, not the pulsatile doses, higher levels of parathyroid hormones, continuous parathyroid hormone increases the bone resorption, leading to increased blood calcium levels. Okay, sir, well and good. Now, does this parathyroid hormone, does it have any action on the intestine directly? There is no direct action. Parathyroid hormone cannot act on the GIT directly. But parathyroid hormone, see, we all know, even in the renal physiology we have discussed, the parathyroid hormone, it will go to the kidneys. In the kidneys, this parathyroid hormone activates an enzyme called as alpha-1 hydroxylase. Okay. So, parathyroid hormone, it activates alpha-1 hydroxylase. Okay, alpha-1 hydroxylase. Now, this alpha-1 hydroxylase, what it will do? It will convert inactive, okay, it will convert inactive vitamin D. Okay, the inactive vitamin D will be converted into active vitamin D, which is also called as a calcitriol. Okay, this is the active vitamin D3. Okay, this is the active vitamin D3. Now, what this vitamin D3 will do? This vitamin D3, it will go to the GIT. Okay, in the GIT, this vitamin D3 is going to increase calcium as well as increase phosphates. Okay, both calcium absorption as well as the phosphate absorption is going to be increased. So parathyroid hormone, see, the parathyroid hormone is not directly acting on the GIT, it's not directly acting. But the parathyroid hormone, by activating an enzyme called as alpha-1 hydroxylase, it activates vitamin D. Vitamin D go to the GIT. Vitamin D helps the absorption of calcium. So I can clearly say the parathyroid hormone, see, acts indirectly in the intestine by increasing the vitamin D levels. Vitamin D, it goes to the GIT, it goes to the intestines where the intestinal absorption of the calcium and phosphates are increased. Okay, so direct action on the bone, indirect action on the GIT by with the help of vitamin D. Action on the kidney already we have discussed, even in the renal physiology also. The same parathyroid hormone, see, parathyroid hormone, yes, it is activating the alpha-1 hydroxylase. Where? In the PCT, Now, directly this parathyroid hormone, it will also act on the DCT. Okay, it will act on the DCT, where calcium reabsorption, not just the absorption happens in the GIT. Now, the calcium reabsorption is going to be increased. So, parathyroid hormone, it acts on the DCT, where the calcium reabsorption is increased. The parathyroid hormone, it will also act on the PCT. Okay, it acts on the PCT. Okay, not the alpha-1 hydroxylase enzyme. That's done. Normally in the PCT, the phosphates are reabsorbed. Okay, the phosphates are reabsorbed in the PCT. But under the influence of the parathyroid hormone, the phosphates are not reabsorbed. So, decrease absorption of the phosphates. Okay, decrease absorption of the phosphates. So, at the end of the day, what I want you to know is the parathyroid hormone. See, parathyroid hormone, yes, it acts on the kidneys. On which parts? It acts on PCT as well as DCT. When parathyroid hormone is acting on the DCT first, DCT, more and more calcium is going to be reabsorbed into the body. So, blood calcium levels are increased. And the parathyroid hormone, it acts on PCT. So that more phosphates are excreted in the urine. Phosphates are not getting reabsorbed. Phosphates are lost in the urine. So, it's like phosphate trashing hormone, PTH, parathyroid hormone. Remember it like phosphate trashing hormone. Phosphates are going to go out of the body. This is something good. Why? Because if you keep both phosphates and calcium in the body, in the blood, the phosphates are going to bind with the calcium. They will precipitate to form calcium phosphates, which is not good. Okay, which is not good. Why? Because we want the calcium in ionic form. We want to have the calcium in appropriate amount in ionic form. So, whenever there is hypocalcemia, in order to maintain the calcium levels, you have to take out the phosphates. Okay, whenever phosphates are there, phosphates are going to bind with the calcium and they will precipitate and form the calcium phosphates. We don't want that. So, whenever there is hypocalcemia, we want to keep only the calcium in ionic form. We want to have the free calcium. For that, we need to take out the phosphates. And who is going to do that job for us? That job will be done with the parathyroid hormone, takes out the phosphates out of the body. So, the free calcium levels will be maintained. Okay, so the action of kidney, say, increases the calcium reabsorption. Okay, increase the calcium reabsorption. Okay, it's not the resorption, it's a reabsorption. Okay, it's a reabsorption. And also, say, increases the phosphate excretion. So, that's why phosphaturic. More phosphates are going to go in the blood. So, at the end of the day, what is the overall effect? See, in a physiological quantities, okay, not excessive amount of the parathyroid hormone. Normally in physiological quantities, the parathyroid hormone tries to increase the blood calcium levels. So, with that calcium, bone formation will happen. So, physiologically in healthy individuals, the parathyroid hormone in pulsatile doses, low concentration, yes, it will cause bone formation. But in severe hypocalcemic conditions, excessive amount of parathyroid hormone will cause bone resorption. Okay, done. Now, after this, let's discuss about vitamin D. Okay, vitamin D, which is also called as calcitriol or 1,25 dihydroxycholecalciferol. Okay, now what this vitamin D is going to do? So, what is the stimulus for the vitamin D? What is going to do on the bone? How it's going to act on the intestine and how it's going to act on the kidneys? Vitamin D. And we already know vitamin D goes to the GIT, helps in absorption of both calcium as well as phosphates. We already know one function. But let's go in an order. So, what is the stimulus for the vitamin D? Okay, what is the stimulus for the vitamin D? Same. When you are having less amount of calcium, see, decrease in the serum calcium, that is hypocalcemia. Decrease in serum phosphates. Okay, so phosphates are going down and increase in parathyroid hormone. Okay, see, you are having hypocalcemia. Whenever there is hypocalcemia, parathyroid glands are activated. Now these parathyroid glands are going to produce parathyroid hormone. So increase in parathyroid hormone, just think logically, whenever there is parathyroid hormone, increase in parathyroid hormone activates alpha-1 hydroxylase. Alpha-1 hydroxylase converts inactive vitamin D into active vitamin D. So what is the major stimulus for vitamin D? Is the parathyroid hormone as well as hypocalcemia as well as hypophosphatemia. Okay, so this is a stimulus. Now what this vitamin D is going to do on the bone? Okay, so now vitamin D, it activates the osteoblast. Okay, vitamin D increase the blood calcium levels. Vitamin D also activates the osteoblast and causes bone formation. Okay, bone formation. And there is also one more function. This vitamin D is also capable of bone resorption, which we will discuss later. So it usually speaking, okay, generally speaking, vitamin D activates osteoblast, helps in bone formation, Okay, now how means vitamin D, it will go to the GIT in the intestine. It increases both the calcium as well as phosphate absorption. True. Now on the kidney, okay, what this vitamin D is doing on the kidney? Vitamin D increases both the calcium as well as phosphate reabsorption. Okay, here it is absorption. Okay, see here it is absorption. Okay, it is resorption. On bone, it is capable of both bone formation as well as bone resorption. Vitamin D capable of both bone formation as well as bone resorption. Okay, in bone it is resorption. In GIT it is absorption. In kidneys it is reabsorption. Okay, so what vitamin D is doing? Vitamin D. Okay, vitamin D does not have any partiality. Wherever it is there, it absorbs both the calcium as well as phosphate, even in the intestine, even in the kidney also. In the intestine, see calcium and phosphate absorption. In the kidney, calcium and phosphate reabsorption. Okay, at the end of the day, what is the overall effect? The overall effect is increases serum calcium levels as well as the phosphate levels. So this is the function of the vitamin D. Now after this, let's talk about the calcitonin. Who produces this calcitonin? Parathyroid glands? No. Now we all know, okay, we have discussed this so many times. Now here is a parathyroid, this is a thyroid gland. Now in the thyroid gland, there are these cells called as the follicular cells. Okay, follicular cells. Now these follicular cells are the ones which produce the T3T4. Okay, these follicular cells are the ones which produce the T3T4. Now there are also cells called as the parafollicular cells. Okay, these are the cells called as the parafollicular cells. Now these parafollicular cells are producing calcitonin. Calcitonin is produced by the parafollicular cells of thyroid gland. So calcitonin is produced by thyroid gland, no doubt. Question is, what is the stimulus for this calcitonin? When calcitonin is produced, see, this parathyroid hormone vitamin D, they will act in a similar way. Okay, they are both, see, parathyroid hormone vitamin D, both are trying to increase the blood calcium levels. But when you have hypercalcemia, when you are having excessive amount of calcium in your blood, then you need to decrease the calcium in the blood. So calcitonin, when do you have calcitonin? The major stimulus for the calcitonin is increase serum calcium or hypercalcemia. When you are having hypercalcemia, then the parafollicular cells of the thyroid gland are going to release calcitonin. Okay, calcitonin. Now, what this calcitonin should have to do? The calcitonin have to decrease the blood calcium levels. It have to decrease the blood calcium levels. How it will decrease the blood calcium levels? By inhibiting osteoclast. See, action on bone. Calcitonin acts on the bone. How? It inhibits the osteoclast, inhibit the bone resorption. When bone resorption is decreased, bone resorption means bone destruction. When bone destruction is decreased, automatically the calcium which is coming from the bone into the blood decreases. So blood calcium levels decreases. Okay, so during hypercalcemia, calcitonin is produced. Calcitonin will inhibit the osteoclast, decreases the bone resorption. Next, what is the action of calcitonin on the intestine? Calcitonin does not have any action on the intestine. No action on the intestine. Now, what calcitonin is going to do to the kidney? On the kidney. See, calcitonin, okay, in the kidney, see, it increases the calcium excretion. When you are having enough amount of calcium, what is the need of further calcium in the body? Okay, what is the need of further reabsorption of the calcium in the kidneys? No, already you are having excessive amount of calcium. So calcitonin is going to act on the kidneys, throws the calcium out of the body. So increases the calcium excretion. What is the overall effect? The overall effect is something very simple. The overall effect is calcitonin decreases the serum calcium. See, decreases the serum calcium. When you are having enough amount of calcium or excessive calcium, yes, the calcitonin is produced. Calcitonin try to decrease the serum calcium levels. Important points, some important points which I want you to know is, see, these parafollicular cells, right? These parafollicular cells, they are the ones which produces the calcitonin. Okay, they are the ones which produce the calcitonin. Now imagine you are having a tumor. Okay, you are having a tumor of these parafollicular cells. then such a tumor of this thyroid gland is called as, anyone? See, the tumor of this parafollicular cells is called as which type of thyroid neoplasm? It's a type of thyroid neoplasm. What is the name of this thyroid neoplasm? The name of this thyroid neoplasm is medullary carcinoma of thyroid. Okay, it's a medullary carcinoma of thyroid. It's a medullary carcinoma of thyroid. Now tell me, in medullary carcinoma of thyroid, which hormone levels will be elevated? In medullary carcinoma of thyroid, calcitonin levels will be elevated. If I am having medullary carcinoma of thyroid, I will be having hypercalcemia or hypocalcemia? I will be having hypocalcemia. Why? Excessive amount of calcitonin will decrease the blood calcium levels. That will cause hypocalcemia. Okay. And what is the tumor marker? If I ask you, what is the tumor marker of the medullary carcinoma of thyroid? The medullary carcinoma of thyroid, the tumor marker is calcitonin. Okay, it's a calcitonin. This tumor or this cancer, I should say, this cancer is producing excessive amount of calcitonin. Okay, now if you take the fine needle aspiration cytology or if you take the biopsy, okay, and imagine now here there is a nodule. Okay, there is a nodule. Now this nodule is because of the medullary carcinoma of thyroid. Okay, I am having a thyroid neoplasm which is presenting with a nodule over here. Okay, now if you take a biopsy, okay, if you take a biopsy, now this is how the slide is going to look. Now you take a biopsy. Now here is a slide which shows, okay, which shows the cells. Okay, which shows the cells. All these are the neoplastic cells. Okay, let me show in blue color because, yeah, see, now all these are the neoplastic cells. Now these neoplastic cells are, they are what? They are follicular cells or the parafollicular cells? They are parafollicular cells. Okay, they are parafollicular cells. Now these parafollicular cells, what they are producing? All these parafollicular cells, now they start to produce this calcitonin. Now this is how the slide is going to look. Now you are seeing the neoplastic cells. Okay, the neoplastic cells are there in the background of this pink color material. This pink color material is nothing but the calcitonin. But previously the scientists or the doctors doesn't know that this is a calcitonin. They thought that this is some kind of abnormal protein deposition. So they just named it like tumor cells are seen in the background of amyloid material. Okay, the tumor cells are seen in the background of amyloid material. So whenever you have that keyword, okay, so of course these are absolutely the pathology topics, but I want you to know these things. Whenever you hear this word, the tumor cells seen in the background of amyloid, tumor cells in amyloid background, you have to immediately think about the medullary carcinoma of thyroid. Okay, this amyloid is nothing but the calcitonin. Okay, it's nothing but the calcitonin. And also remember, this medullary carcinoma of thyroid, it is associated with MEN2 syndrome, both 2A as well as 2B. Okay, see, in men, multiple endocrine neoplasia 2A and multiple endocrine neoplasia 2B, in both the syndromes you will have this medullary carcinoma of thyroid association with multiple endocrine neoplasias type 2, which includes both 2A as well as 2B. Okay, so with this we are done with the three important hormones which are maintaining the calcium homeostasis, that's the parathyroid hormone, vitamin D as well as calcitonin. Okay, now let's discuss some more important systemic hormones, how they will affect the calcium homeostasis. See guys, these glucocorticoids, what the glucocorticoids are going to do? See, glucocorticoids, they will decrease the calcium absorption in the intestines. So by that, they decrease the plasma levels of calcium. So glucocorticoids are all the time against the blood calcium levels. Okay, glucocorticoids, they are all the time against the blood calcium levels. Okay, glucocorticoids decreases the plasma calcium levels. Okay, now apart from that, what about the growth hormone? Okay, what growth hormone is going to do? See, the growth hormone increases the intestinal absorption of the calcium. Okay, by increasing the intestinal absorption of the calcium, it increases the blood calcium levels. Okay, done. Thyroid hormones, what they are doing? See, thyroid hormones are more like catabolic hormones. They causes the bone destruction. With that, it increases the blood calcium levels. So causes hypercalcemia and even hypercalciuria. More calcium in the blood as well as more calcium in the urine. So thyroid hormones causes hypercalcemia as well as hypercalciuria. Now estrogens, we all know. Okay, something very important. Okay, during menopause, the estrogen levels goes down. Ovarian failure is there. Less amount of estrogens are getting produced. Whenever the less amount of estrogens are there, now osteoclasts are activated. Osteoclasts will cause bone resorption or bone destruction, which will increase the calcium levels in the blood. Okay, we all know that story, but simply, estrogens are osteoprotective. Till the time female is having estrogens, what these estrogens will do? Okay, imagine a 20-year-old female, she is not going to complain that she is having back pain or she is having joint pains. Why? Why? A 20-year-old female, 30-year-old female who is having enough amount of estrogens in her body, she will never complain that she is having bone pains. Okay. Why? Because she is having good amount of estrogens. These estrogens are osteoprotective. Estrogens inhibit the osteoclasts. When the osteoclasts are inhibited, no bone resorption. So estrogens prevent the bone resorption by inhibiting the osteoclast. Okay, this is something very important. Okay, now look at here, I will tell you how these estrogens are osteoprotective in a female who is not into her menopause. Okay, so before 50 years, female is not in the menopause. Now she is having a good amount of follicles in the ovaries. First of all, let me ask you something. What exactly is menopause? What exactly is menopause? See, menopause means simple, a female. Okay, now whenever she enters into a 50 years or 55 years, 52 years, what happens is her ovarian reserve is going to decrease. Ovarian reserve decrease means now usually in the ovaries, there are many follicles present, many oocytes present. With the time, the follicle count will be decreased. By the time she comes into 50 years, now the follicles in her ovaries are completed. All the follicles in her ovaries are almost gone. Now, we all know that the follicular cells, okay, now the follicles, the ovarian follicles, they will produce estrogen. So, by the time she is 50, a female by the time she is 50, her follicles, ovarian follicles, they are gone. No follicles are there. So, what happened to the estrogens in a female who is 55 years old? Now, there are no estrogens. Estrogens are not there. Whenever the estrogens are not there, what will happen? Osteoclasts will be activated. How osteoclasts will be activated, we will discuss now. See, normally, okay, physiologically, what happens is, see, normally osteoblast, which are the bone forming cells, they form the bone, right? Osteoblast, they will produce something called as a rank ligand. Okay, rank means a receptor activator for nuclear factor kappa B, which is not that important. Important point is the osteoblast, they will produce something called as rank ligand. Okay, they will produce something called as rank ligand. Now this rank ligand, it will go and bind with the osteoclasts. Okay, it will go and bind with the osteoclast, which means the rank receptor, where it is present, rank receptor is present on the osteoclast. Rank ligand, okay, rank ligand is coming from the osteoblast. Now this rank ligand, it will come, it will bind with the osteoclast. When rank ligand binds with the osteoclast, what happens? Rank ligand is going to activate the osteoclast. Now these osteoclasts are going to do the bone resorption. So at the end of the day, what I want to put into your mind is, usually students will think osteoblast and osteoclast, yeah, they are opposite cells, they will be doing the opposite actions. It's true, but the osteoclastic activity is regulated by the osteoblast. Okay, the osteoclastic activity, it is under the control of osteoblast by producing rank ligand. Okay, now what these estrogens are going to do? In a female who is not in her menopause, these estrogens, they will act on the bone marrow stromal cells. Okay, in the bone marrow stroma. Okay, the estrogens are going to act on the bone marrow stromal cells. Now, these bone marrow stromal cells, okay, the bone marrow stromal cells, now they will produce something called as osteoprotegrin. Okay, osteoprotegrin, which is a decoy. Okay, which is acting like a decoy. Now, when the osteoprotegrin is there, okay, it's like a more beautiful girl. Now, this rank ligand, instead of going to the osteoclast, okay, it was supposed to go to the osteoclast, but under the presence of this osteoprotegrin, now this rank ligand is going to come and bind with the osteoprotegrin, so that rank ligand is not going and activating the osteoclast. So, what I am saying are estrogens, they act on the bone marrow stromal cells, helps in production of osteoprotegrin. This osteoprotegrin is acting like a decoy receptor. Now, this osteoprotegrin will inhibit the rank ligand. It will inhibit the rank ligand, so that osteoclasts are not activated. Okay, when premenopausal woman, in premenopausal woman. But whenever she goes into the menopause, see, after menopause, what happens? Estrogens are not there. Why estrogens are not there? Why? Because all the follicles are completed. No ovarian follicles. She is not having follicles. Whenever she is not having follicles, estrogen is not there. Osteoprotegrin is not there. Whenever osteoprotegrin is not there, again this rank ligand, now it will go to the osteoclast. See, after menopause, the osteoprotective effect of estrogens is lost. Now she is going to have activation of osteoclasts in her body. Osteoclasts are going to do the bone resorption. Now, whenever there is bone resorption, her bone mineral density is going to be affected. So that what happens? It will lead to fractures. Which fractures? It's going to cause a compression fractures, especially the vertebral compression fractures. So the vertebral compression fractures are the most common fractures, especially seen in a female who is in her post-menopause. Okay, post-menopausal female, it's the vertebral compression fractures which are most common because of the osteoporosis, followed by the wrist fractures or the Cooley's fracture. Okay, wrist fracture, even the femoral head fractures, all these are going to occur in the post-menopausal albumin. Now after this, let's discuss about the drugs which are used in the treatment of osteoporosis. So now let's discuss about the first group of drugs which are called as the bisphosphonates. Okay, see, these bisphosphonates are considered as the drug of choice for the treatment of osteoporosis. So bisphosphonates are the drug of choice or the first line drugs in the treatment of osteoporosis. Well, what are the examples of these bisphosphonates and what exactly they are doing? These bisphosphonates, they include alendronate, zoledronate, pamidronate, ibandronate, all these drugs. Dronates, which ends with alendronate, ibandronate, pamidronate. See what they are doing. See, if you want to treat osteoporosis, okay, either you have to activate osteoblast or either you have to inactivate osteoclast. Okay, either you have to inhibit the osteoclast or either you have to activate the osteoblast. Simple logic, right? See, now these bisphosphonates, what they are going to do? These drugs, whenever you take these drugs, these bisphosphonates will be taken up by the osteoclasts. See, osteoclasts are going to take up this bisphosphonates and immediately they will undergo apoptosis. So, bisphosphonates are going to induce apoptosis in osteoclasts. They will kill the osteoclasts, or I should say inhibit the osteoclasts. Whenever the osteoclasts are inhibited, what happens? Bone resorption is going to be inhibited. Whenever the bone resorption is not there, that is something good in osteoporosis. That is something good because only bone formation will be there. So the bone mineral density will be increased. So inhibit the osteoclasts and they are the drug of choice or the first line drugs in the treatment of osteoporosis. But important side effect of this bisphosphonates. See, whenever you are prescribing this bisphosphonates to a postmenopausal female, actually you ask her to take it with a high amount of water. She have to take lots and lots of water because it will cause esophageal irritation. Okay, esophageal irritation, it will cause even esophagitis, and sometimes as a rare complication, this is MCQ, as a rare complication it will even cause the osteonecrosis of the jaw. Okay, so these are the important side effects. See, esophagitis and esophageal irritation are the I have already explained to you about this, and osteonecrosis of the jaw. She have to take with excessive water, and she haven't she shouldn't lie down. Okay, especially for the next half an hour or 40 minutes, should not lie down. Okay, that will cause reflux esophagitis, a lot of complications are there. So bisphosphonates, they are the drug of choice, inhibit the osteoclast, causing apoptosis of the osteoclast. Done. If you know this, enough. Now let's talk about raloxifene. Sir, what exactly is this raloxifene? Raloxifene is a SERM. Okay, raloxifene is a SERM, that is selective estrogen receptor modulator. Now we all know estrogens are protective, estrogens are osteoprotective. So now in this postmenopausal female who is suffering with the osteoporosis, let's give her drugs like estrogens. But something problem is we are doing something against the nature. Nature have taken out the estrogens at 50 years. Okay, at 50 years, nature have taken the estrogens back, or nature have decreased the amount of estrogens in the female. Now what you are doing, you are giving the estrogens to this postmenopausal female. What will happen? These estrogens, they will go and protect the bones, no problem. But these estrogens in postmenopausal female might cause the uterine cancer or the endometrial cancer. It might cause the breast cancer. Okay, so what we have to do, we have to focus on the target. Now you have to give the estrogen, and that estrogen should have to act only on the bones but not on the breast as well as the uterus. So you have to use such a drug which will go and stimulate the estrogen receptor only on the bone but not on the uterus or not on the breast. Because if it is stimulating on every place, bone, uterus as well as breast, it will cause uterine cancer as well as the breast cancer. So now we are using a drug called as the raloxifene. It's a selective estrogen receptor modulator, selective estrogen receptor stimulant. So see, it exhibits estrogen like action on bones but antagonistic action on the breast as well as uterus. So now can you tell that this raloxifene is going to increase the risk of uterine cancer? No. Is going to increase the risk of breast cancer? No. So side effects, see, heart flushes are there, retinopathy, venous thrombosis, okay, they are there. Estrogens are they are going to increase the clotting factor. They are hypercoagulants in the blood, we all know. So that's why yes, venous thrombosis can happen and the thrombosis can lead to the retinopathy, heart flushes can be there. But they do not increase the risk of endometrial cancer. They do not increase the risk of breast cancer. Okay, done. So bisphosphonates completed as well as the important drug, that is the raloxifene, is also completed. Now let's talk about the teriparatide. See here, the name itself is there, para. What is this paratide? Parathyroid hormone. Parathyroid hormone, para. See, normally you will think parathyroid hormone, what it will do? It will activate the osteoclast. It is going to cause a bone resorption, increase the blood calcium levels, right? See, I have explained to you, specifically I have explained to you. See, parathyroid hormone in higher quantities, will activate the osteoclast. But parathyroid hormone in physiological quantities or in pulsatile doses activate the osteoblast, helps in bone formation. So see, teriparatide is nothing but recombinant parathyroid hormone. How you have to use this drug, teriparatide? You have to use these drugs in pulsatile doses. When you are giving in low doses, okay, in regular intervals, little by little, they are going to activate the albumin hydroxylase. They are going to activate the vitamin D. Not only that, this teriparatide, parathyroid hormone, activate the osteoblast, helps in the bone formation. So acts on the osteoblast, helps in bone formation, which is used in the treatment of osteoporosis. Done. Now after this, let's talk about a drug called as a denosumab. See, denosumab. Please concentrate on this. MAB for monoclonal antibody. Okay, MAB for monoclonal antibody. So denosumab is a monoclonal antibody. What this denosumab is going to do? Denosumab, it inhibits, see. Now denosumab, now it is acting like osteoprotein. Okay, now it is acting like an osteoprotein. It's acting like a decoy receptor. See, now this denosumab, monoclonal antibody, now it will directly go and it inhibits the rank ligand. So now rank ligand is not free. Rank ligand cannot go and activate the osteoclast. So rank ligand is inhibited. So osteoclasts are not activated. They are not activated. So no bone resorption. So denosumab, yes, it's a monoclonal antibody given subcutaneously. This is one of the important MCQ. How you have to take this monoclonal antibody? Yes, subcutaneous route. What this denosumab is going to do? It's a rank ligand inhibitor. Okay, so far the drugs which we are discussing, either they are activating the osteoblasts or either they are inactivating the osteoclasts. Okay, but there is this one drug which is called as the strontium renalate. Okay, this is something special drug. Now the strontium renalate, it knows the exact thing what it have to do. It is having two hands. With one hand, it is going to activate the osteoblast, and with the other hand, it is going to inhibit the osteoclasts. Okay, so tell me one drug which is used in the treatment of osteoporosis, which is going to act on osteoblast as well as it's going to act on the osteoclast. It's the strontium renalate. So strontium renalate, what it will do? It inhibits the bone resorption. Okay, it inhibits what? It inhibits bone resorption as well as it stimulates bone formation. That is inhibiting the osteoclast and stimulating the osteoblasts. Okay, so with this, we have also discussed the topic of the calcium homeostasis, the hormones which are regulating the calcium levels in the plasma, and also we have seen the small topic which is the osteoporosis and the drugs which are used in the treatment of osteoporosis. Hope the video is helpful. Thank you.